Let's see. Recording has started. So welcome, Dr. Elchar.
Yeah, thank you for having me, Jim. It's always a pleasure to work with you. I'm Edgar Alchar. I'm a periodontist by training. I finished in 1997 from NYU, and I did a master's in oral biology. And then I practiced privately for 25 years now. And I also did run the postgraduate at NYU for 10 years. I left in May 2021 and did a big career in teaching, and I published a lot with Jim. He's been amazing to have the podium for me with editorials. So every time I have a good idea, I throw it to him and never says no. So that's great, and I love that. And so I know Dr. Rutkowski for over 10 years now, if I am not mistaken. And since you became the editor, actually. So
Yes.
I don't know how long this has been, but so I've published a book. I've published quite a bit of things, and now I started a podcast where I talk about periodontal disease, health, systemic health, and then since I'm doing an MBA, a dual master's actually, MBA and master's in healthcare leadership. As you mentioned, I am a student. I will finish hopefully by May 24. I didn't know what I was thinking when I went there. And so it's at Cornell. It's not a joke. So they put a lot of pressure, a lot of assignments. We just finished an assignment. And it opened my mind in a different way. It opened my mind in how is the healthcare? How is it going there? And how can we understand the dental industry? How has it changed? And so I had a lot of conversation with you about that. And I did run a couple of podcast on this matter. One with the Dean of UPenn, a dear friend of mine, Dr. Mark Wolf. He's a mentor. And then I did with one healthcare economist and one lady that she is the Associate Dean at Clinical Affairs at Weill Medical Cornell. And she also involved in the healthcare leadership. So that has been a big opener for me. So we can discuss that, but the most important is we decided we're going to talk about where is the periodontal disease or the healthcare, oral health in the huge healthcare, and how is it going to be impacting the economy, and something that we as a dentist, we don't think about it at all from that perspective, unfortunately, and all our academies are not doing the right job for that. So with that, I thought we will give a small talk about this, and hopefully in the future we can talk more about economics. Where is the dental industry heading? Because that's very important for you to know, as well as I gonna help you with a lecture series. So I'm looking forward for that. So
Yes.
whenever you're ready, I can share the screen and I can talk a little bit about that the periodontal disease or the oral health in the healthcare and the
Okay.
economical impact.
Okay. We're ready for you to share the screen. Are you familiar with how to do that in Teams?
Yes,
Okay.
indeed.
Very
Uh,
good.
I need to just figure out if my lecture is on. Just give me 1 second. Yes, it is. And this is, I'm going to minimize. And there you go. Okay, can you see my screen?
Yes. If you can make that. Yeah.
Yeah.
Yes. Thank you.
Okay. So that's the title, and I emphasize on oral health as a comorbidity and its financial impact. And you will see throughout the conversation why I emphasize on that in particular. So if we go ahead and we think about it, the driving factors in dentistry has been and will always be the majorly is implant dentistry, aesthetic, and yes, we talk about oral health, but this one is very not really taking a front row, and that's what I want to share with you why and what I mean by that. This is a patient that came to me. She was 37 at that time, and you can see her implants has been exfoliated from her two central area. But if you look carefully more, you can see that there is a problem on the molars, problem on the lower incisors, and problem on the first molars. So usually when you have a pattern of molar and incisor, then you should start thinking that that must have been a periodontal disease of early onset that has been missed or never been diagnosed properly and treated properly. And you can see the amount of damage that this happened to the patient. And when we look at the CBCT, you can see it's really a big problem. And you can see it here very carefully. You can see the damage on the centrals. You can see that the molar here been replaced by implants. So again, the molar incisor pattern. And that is significant because when you look at the oral DNA, you can see that she scored extremely high in the red complex. That's what we call in periodontics the red complex. And even if the threshold that's been placed by Foresight has not been reached with the AA, the fact that you detect AA, which is a huge thing, that can correlate exactly that this patient has had a periodontal disease that went unchecked all of these years that led her to this big problem. So moving along, I just had this patient referred to me. This patient is going for Olonex on the bottom. The top is manageable. But the striking point in this is that this patient has been struggling with diabetes for a long time. She's a smoker, and her physicians never asked her at all, how is her oral health? And that is the most striking point. And when you look at it from both sides, you can see the amount of plaque and damage that we have. And moving forward, when you look at the radiographs, you can see the advanced periodontal disease on the bottom. And we will see later that this is what we called under stage 4. And on the top, it is more manageable, even in the periodontal charting. So that will lead me to the periodontal diagnosis that took place in 2017, but was published in 2018. Now, this is something important to talk about because we've missed a very huge opportunity as dentists to move our profession to more into the healthcare and to look at ourselves that not only we are dentists, but we are part of the healthcare providers. And this is very important to elevate ourselves to oral healthcare providers. And that's very important. And we are missing a lot. But when we look at this diagnosis, there is a lot of things that have been said in it that are very important. One of them is gingivitis is a reversible disease. Periodontal disease is not reversible. It is a journey that needs a lifelong support, lifelong supportive care. And that's what I want you to remember. It's not curable, but yet it will require a lifelong support. Now, this will bring us to another point that was very important in that periodontal diagnosis. There's strong evidence that there's an increased risk of developing peri-implantitis in patients who have a history of chronic periodontitis, poor plaque control skills, and no regular maintenance care after implant therapy. And these are major points that we have missed in educating the whole community about that. And if I move forward, and you can see the new diagnosis was divided in this way, the most important thing that took place is, other than they introduced the peri-implant diseases, which we did not have a diagnosis for, it is the gingival health. And that's what I want to emphasize too. Gingival health or periodontal health. Both of them are very important point because till that day, we did not have a definition for health, oral health. You see, remember how I'm taking you. Forget about the word periodontal or gingival. It is the oral health. And that's where we miss the point. And we go to physicians and they say, you know, Dr. Rutkowski is a 25-year-old young man and he is healthy. When they say healthy, there is a basis for it. And that we did not have in dentistry until recently. And when we look at it, it is no attachment loss. And when we talk about attachment loss, we talk about interproximal loss, not the recessions on the buccal, but attachment loss or recession on the proximal side of the teeth. That's a very important nuance that we need to keep in mind. Secondly, we have a pocket depth that is less or equal to 3 millimeter. So that's the criteria for health. And less than 10% of the mouth has a bleeding upon probing. And definitely no bone loss. Now, the opposite to that is gingivitis. It is over 10%, still the probing the same, but you have more inflammation, more bleeding. And you can have also periodontal health with mucogingival deformities. What does it mean? Means that somebody has a recession, but yet the periodontal disease does not exist. They have periodontal health. That means somebody has, sorry about that, 1 second. You have a periodontal health, meaning pocket 3 millimeter or less than 10% of bleeding, and on top of it, they have a recession.
We love dogs. What kind of dog is it?
It's a golden doodle. Hold on with me 1 second.
Oh, I love dogs. For those of you that are going to be listening to this on the tape, Dr. Elchar has gone to attend to his golden doodle for a moment. So
yeah,
he's back now.
That's an interesting thing when you have a golden doodle. They get excited every time.
Yeah.
So you can have a recession, buccal recession, or lingual recession, not interproximal, but you have health. So that's important point. And gingivitis, as I mentioned briefly before, you have no attachment loss, same thing as the health, same probing depth, but you have inflammation, meaning bleeding upon probing, and definitely no radiological bone loss. Brings us to the periodontitis. Periodontitis becomes different. You have to have pocket, obviously, above 3 millimeter. You have to have attachment loss interproximal, and you have to have bone loss, obviously. So that goes like it's very simple. Now you can have other things affecting it, like the traumatic occlusal forces, endoperio, whatever else. So if we move forward to that, then we can have also periodontitis with systemic disease, like leukemia, for instance. So these are very important. You can see that the systemic disease or the systemic condition is part of the periodontal diagnosis. Now, there is also an addition that took place, which is the staging and the grading. I'm not going to get into too much detail about it, but nevertheless, the staging, it's like you have periodontal, God forbid, you have cancer, and they tell you stage 4 cancer. What means? It means it's finished. Like that patient that I showed you, it means all the teeth are gone. Stage 3 is different. That means it is advanced, but it's not final. 2 is moderate, 1 is initial. So it's very common, but what's important is the grading. The grading is how is it going to progress with time? And if we look into it, there is a very important point to mention. One is the direct evidence of progression, which is the follow-up of the patient, and you can see they have a progressive bone loss. The second indirect is the correlation between age and bone loss. For instance, if you have a young patient that comes with a lot of bone loss or periodontal disease, then you have to throw them in grade C, because that means in long term, they're going to lose their teeth. And where it's important is you can't have also the grading depending on the medical condition and the smoking. So you can see the correlation between the effect of systemic disease or systemic condition on the periodontal disease and vice versa. Because diabetes, it is a bidirectional correlation, and we will touch on it very quickly, but you can see it is correlated to the A1C. And once you compile all of this, you come up with the periodontal charting that it is exhaustive, but it is important. It's more important nowadays than it's ever been. And that's why I wanted to take this opportunity, thanks to Dr. Rutkowski, to tell you about these things, because, you know, foundation is periodontal, a foundation, it is oral health, and that's what is important. And as I mentioned to you, we're going to put implants, but we need to have a clean mouth when we put implants. So when we move forward, there is the peri-implant diseases, and that's what we are used to, the peri-implantitis and mucositis. Mucositis, more inflammation of the soft tissue around an implant without bone loss. Peri-implantitis, it is inflammation with the presence of bone loss. So having mentioned all of that, when we look at the periodontics in general, you can see that the benefit of the periodontics is to lead to an oral and general health. And also it has a component, like we started with that trilogy, one component is at the end is dental implants when the teeth are failing, or aesthetic when you do the aesthetic crown lengthening and or soft tissue grafting. So that's how I look at periodontics, that it's a big player that is important into the multidisciplinary treatment planning and understanding of it. So when we look at oral health, we can divide oral health into two things. One is the periodontal disease, but also one is oral medicine. Now, what do we mean by oral medicine? We mean about lesions in the mouth. And, you know, this is something I have been very big on. I had the opportunity to learn from two great people. Unfortunately, both of them have passed away. One is Dr. Sheldon Ross, and one is Dr. John Fallon. And the latest, Dr. Fallon, has really influenced me a lot. He used to sit me and show me on the microscope stuff like this. And so I have learned quite a bit. I had the honor to do that and the opportunity to do that. And you can see this is a patient who was referred to me for 2 recessions on 24 and 25. Now, as a periodontist, it's important for you, if you're working with a periodontist, don't send them x-ray for the region only, because they are, by law, have to assess the whole mouth. If they miss something, they are liable in a court of law. So that's something just I wanted to throw out there, because I just had a patient referred to me with 1 x-ray of 1 area. That creates a big problem, because we have to see if there is other things. It's not like an oral surgeon, they do only per consultation. So I did do oral examination, and you can see here, this is the linea alba. It looks, you know, very innocent, but when I took the perio probe and I passed it along, I saw this filiform coming out. I took a small biopsy of that and I sent it to the microscope, to the pathology, and that's how it became. It's an HPV. So you don't take anything for granted in the mouth. You don't know what you're going to find. Look at this tongue. You have 2 sides of it. One was a hard exophytic line of white color, and the other one was round like a cauliflower. So I biopsied both of them, and both of them came out as a HPV. One is a vulgaris, which that's what you get on the fingers or on your toes, and the viral is the other one that was that white sticking out. So if we look at malignancies, this is one of my first cancer that I've diagnosed. This patient was coming for full implant placement on the mandibular. They missed it as a exophytic tissue from a ill-fitted denture. Somehow it didn't sit well with me. At that time I sent it to a neurosurgeon and it came as a verrucocarcinoma. This is manageable. They removed that whole area, but he was healed and he came back and he ended up having his implants. But this one was drastic. This was a melanoma, very rare to find in the mouth. And this is when I was director of the postgraduate. And my student at that time, Dr. Alejandro Castaño, did a biopsy and we ended up with a melanoma diagnosis. At NYU, oral surgery wanted to do hemisection of the top and bottom of the arches. He researched it, that young fellow at that time, Dr. Castaño, which I was very proud of, and he ended up finding him a immunotherapy treatment at NYU Medical Langone, and he saved his jaw. So he was really well treated, and we ended up writing a paper on that finding. And this is recently in my private practice. This was actually a T-cell lymphoma. This is it's a matter of time before they pass away. It's very, very rare, but very, very aggressive. The patient had fever, had lesion. They wasted their time doing blood tests, and it was by the time she told everybody that she has something in the mouth, and she came, and that was it was weird. It looked like a fungus, or it can be necrotic, but biopsy proved it, and so that's how we ended up having the diagnosis. So having said that, we as a dentist, very important to understand and do a good comprehensive oral examination. Moving to the periodontal disease. Periodontal disease is as we said, incurable but containable. And the treatment always starts with diagnosis to initial therapy to surgical therapy. And in it, it can be regenerative or it can be an osteosurgery. And when it fails, then we can move to dental implants. Or even within the component of the treatment, it can be a dual treatment of periodontal disease and implant placement for teeth that they are unsalvageable. So having moved that, now we're going to get to the last 15 minutes talking about periodontal disease with systemic health. And that is important because it is, as you see, and this is only 4 that I picked for you. There's others, like Alzheimer, but I want to pick on these. And periodontal disease and pregnancy, periodontal disease and diabetes, periodontal disease and rheumatoid arthritis, periodontal disease and cardiovascular diseases. So if we look at the periodontal disease and pregnancy, well, the correlation is that they are finding inside the placenta periodontal pathogens, such as Porphyromonas gingivalis. And that is affecting or going into the bloodstream or affecting the early childbirth, which leads to a nuki, they call them. So there is a correlation there, and it's still into the pattern of understanding it. You have also with diabetes, as I told you, it's a bi-directional relationship, meaning somebody who has diabetes is more prone to have inflammatory disease in the mouth, and having an inflammatory disease in the mouth will lead to more bone loss. And also periodontal disease that went unchecked will lead also to higher level of glucose in the blood. Secondly, the periodontal disease and rheumatoid arthritis. And that is a very interesting point because it is an inflammatory disease. So you have an inflammation and then you have a dual inflammation that you end up more exacerbation of the rheumatoid arthritis. And leading to the periodontal disease and cardiovascular diseases, you can see that there is a big paper that was the World Health Federation and the European Federation of Periodontology they found a huge association between periodontitis and cardiovascular diseases because they were able to locate Porphyromonas gingivalis again into the plaque that builds on the arteries. Now, the theory is that these bacteria are nicking the arteries, and that will lead to more plaque adaptation. That's one of the theories. So there is a correlation. The fact that we are still not accepting it as a big comorbidity, that it's mind-boggling for me. And so the impact on public health, and I want you to understand it very well, that, and you can see here in that paper, that patients, once they cross the 65, they are a 70% more risk of periodontal disease, 70% more. Now, you ask me, so why would that happen? Well, it's more of a dexterity, a consistency of treatment, because periodontal disease is containable. And if you look at it at the population in the United States, and that's something that is very important. That's what one of the biggest points that I learned from the part of my dual masters in healthcare. It's that we are aging population in the United States, in the world, but in the United States, after 2030, we're going to have 25%, not 21, 25%, actually, that was a little bit old, that paper, of baby boomers. So they will fill in the gap. So you're going to have a lot in the third bracket of age that they're going to live long. So that's a very important thing. So what are we going to do with these people? They have 70% increased chances of having periodontal disease. So that is a big impact on the public health and on the economy, because they need to have treatments, and that is going to be expensive, and that is not going to be covered by the retirement that they're going to get. So when we look at it also in the United States, forget about only the aging population, it's the poverty. And when you look at United States down south, and you look at the Mississippi, Alabama, and all of these, this is where the highest amount of periodontal disease, it's correlated to poverty, obviously, goes without saying, but also it's correlated, although everything now it's popular in the United States to talk about race and disparities and all of these things, but let's put this aside. It is education, bottom line. And you can see that periodontal disease is much higher with people don't have a high school degree. So the more educated the patients or the population, the better the outcome of everything. So let's not only focus on the race, but focus on education and opportunity, obviously. So if we think about it, poverty, education, and access to periodontists, because if you look at New York, I live in Manhattan. We have tons of dentists, and actually the majority of the dentists in New York State is here in the 5 boroughs, but not in upstate or the other counties. So this is a big problem. Everybody stays in metropolis. The rural or out the fringes or the other counties in any state don't have access to periodontists. So that is, again, another big problem. Now, when you think about it in the poverty, that's what I want you to stick in your head. So we have periodontal disease. We know it. It's there. The numbers in front of you on the screen. And these patients are mainly living off of Medicaid. So who do you think is paying on it? You and me. So that is a big impact on the economy, because when we pay for it as a taxpayers, we know that these people have no opportunity to get any periodontal or dental. We know that. We don't take care of it. It's affecting also their health in general, so that's compounding the effect. And that is something very important that we don't pay attention. Now, think about that. That is a big chunk of the population, believe it or not. Then you have now a bigger chunk of the population, either them or the wealthy, that they're going to be also, or middle class, that they're going to be retiring or getting into the third bracket. And we know for a fact that the periodontal disease is going to increase with age. So who's going to take care of them? So with that, I want you to remember that given these disparities and the link between periodontal disease and systemic comorbidity, unchecked progression can pose significant cost burdens on the healthcare system, emphasizing the need for public health intervention. And that is the most important thing, that if I can convey that message to you, to think about it differently than when we learned in dental schools. We are now adults. We are the future of that profession. I'm Generation X that nobody talks about. So my friend Jim is moved into the baby boomers. So you are the next generation. You are the next frontier. That you need to understand that effect of this problem and carry that message that it's important to take our a profession and move it from being a repair to more of a healthcare providers. Be it oral healthcare provider or healthcare provider, but it's the same thing because one cannot live without the other. So with this, I always like to do something I call Sha'arisms. And from the Sha'arisms, I always say those three things, meaning coming from my name. Biology always wins. Fundamentals never change, and we have to set a goal and walk our way back. And this is very important. If you allow me to explain to you why I've been saying it, if you attended a lecture of mine before or you've never, and now you're seeing it, I always repeat those. And this is important because biology at the end of the day dictates all the outcomes. So if you have a periodontal disease and you don't take care of it, it doesn't matter if you place an implant or you replace with an implant, but you miss the diagnosis of the mouth, this is going to affect the outcome of the result. So if you think about it, everything we do is based on fundamentals that we studied and we build upon it. And at the end of the day, if we are dentists and we want to place an implant, we are going to place it in the most prosthetic-driven way. Or we have to put a goal for ourselves. I want to become bigger within 10 years. I want to become such and such an X, whatever it is. You have to set a goal and you put yourself to it. Same thing with the treatment. You have to set a goal, and from there you see what we can get to there. And with that, this is all my contacts, and this is how you can find me on social media or on you want to listen to my podcast and the YouTube, watch them. But I wanted to thank Jim for giving me this opportunity. And now I want to have we did a small talk about this, but I want to turn it into more of a conversation because at the end of the evening, lecturing only is not beneficial, but having a two-way conversation is probably more beneficial for you and for myself and for me. So I'm all here for you to ask me any question about it. And I hope it was different than what you thought in your career.
First of all, thank you for the presentation. I've been taking quite a bit of courses with perio from Dr. John course for like the past year and stuff like that. And I've noticed that I do agree with you that periodontal disease has to be a healthcare management, but do you think in order for us to go in that direction, that the other side of the medical community need to recognize dentistry and perio, and they need to work with us? So like that perio affects the heart, all of that, Alzheimer's, diabetes, all of that. So if we have MD doctors in those communities, like let's say a person getting heart surgery and they want to maintain their life afterwards, but they should be willing to work with us, like sending the patient to us, be like, oh, you have major surgery. I want to make sure you have nothing wrong going on in your mouth. Fine. As long as the dentist checks you off, say you're good, fine, I'll do the surgery for you.
Yes, that is
a collaboration.
Yeah, that is a very valid point, and that's what I discussed with the dean at UPenn and the dean of Weill Cornell. How can we, in there, based on the dean at UPenn, there's something went wrong between dental and medical. They went part way. If you look at, I have a, not anecdotal, it's a true story. I have acquired another practice uptown, and a lot of the population of their certain age, and I noticed that a lot of them on a lot of medication, especially Prolia and bisphosphonates, and they have periodontal disease, and they've never been checked by us about it. So started making phone calls with doctors, and one of them that was most striking is that she had this puffed up, the patient had this puffed up papilla, and had periodontal disease, and I told him, did you change medication? He said, yes. Like, matter of fact, my primary went to concierge medicine, and now I have a new one, younger, and she gave me amlodipine. I mean, this is a calcium channel blocker, goes without say. So I called the physician. I said, you know, so-and-so has this because of the dose. Can we switch him to something else? I have not, I didn't know that that caused this. I didn't know that amlodipine causes gingival hyperplasia. Now, I mean, I was very polite. I didn't say anything, you know, unprofessional and stuff. But that did not sit well with me. That where is wrong? Where went wrong? In between the medical education and the correlation between the two together. And they give them a course, like 2 hours, 3 hours about dental anatomy, nothing more than that. That's for them what is dentistry.
Could I hop in just for 1 second?
Please.
And I am so glad that you said that, because physicians, they're very good, and they get a very good education at diagnosis of disease states, interpreting lab tests, knowing what they should prescribe, but they get no better pharmacology than what dental students get. And then afterwards, at least some dentists realize they've got to learn more pharmacology, and they do. But most dentists, if they had to rely on what they learned in dental school, they don't know that calcium channel blockers induce gingival hyperplasia just based on what they have in dental school from 15 years ago. And so physicians are no different. They're getting their drug information most often just from the reps that are coming in, and they're telling them they have got 10 minutes to get in there, do a little bit of socializing. Now go ahead and tell them this is our newest product and this is what it does, and we're out the door. And they're never taught pharmacology, just as dentists really aren't. But fortunately, dentists, they realize they've got that void, and some of them do go back and get pharmacology courses. But that's true with that pharmacology. And so we can't assume they know dentistry any better than they know pharmacology, because they don't know pharmacology. They know how to spell the name of the drug, how many milligrams, and how often you give it, and that's it. They don't understand dentistry. And in my practice, my number one referral base were physicians. That included general practitioners, as well as endocrinologists, as well as cardiologists, internal medicine. And that's the relationship that we do need to have. It's that joining between it. And I want to just, you started out with about the implants there, and people come in and they get these all-on exits. Well, they spend $30, $35, $40, $50, $60, $70,000 on these all-on exits, maybe upper and lower, but they never master the periodontal disease. And these people are beyond the age of 70. And just as my first home, which is usually the biggest expense a person has in their life, was $28,000. Now you spend that on a dental treatment, one arch.
Correct.
Or more. And so that financial burden on that retired person.
Indeed.
all of a sudden we're going to take $28,000 of your whatever it is you've accumulated. And then if it's not going to last, the repercussions back on that implant dentist, on that person, not just thinking selfishly of the implant dentist, but of that person who took $28,000 when they might be getting $3,000 a month in Social Security.
Correct.
You took almost a year's worth of income.
Yeah, that's exactly why I was happy when, Jim, you told me, why don't we have that discussion? Because I'm happy to have this forum of discussions, because those are not something anybody talks about. And just to second what you said, clear choice, spent billions of dollars in advertisement and stuff. They did good for us because they, we get more patients informed, blah, blah, blah. But look what they do. Clear choice, they place the implants and they tell you, go back to your dentist. They wash their hands and they make you sign about that. Why? Because if the dentist does not know how to maintain those implants, they are responsible. So they drop the responsibility back into the fold of a dentist that probably doesn't know how to maintain them. And there's a fear of, oh, if I use the Cavitron, or if I do this, or I do that, oh, the implant is gonna, I don't know what's gonna happen to the implant. But yeah, it can get worse if we don't remove the plaque than nicking it or whatever it is. So these are very valid point, because $28,000 in North Carolina or South Carolina or Alabama, it's a lot of money, a lot of, and it was, like I said, this dual program that I'm doing opened my mind about how we are missing the point in a lot of things. And I tried to get this dean of my Cornell to answer those questions. She answered them, but did touch the bullet on it. I could spin it out. There's no interest. You don't find a very interesting point. I am trying to write a paper in periodontal disease and as a public health issue. I don't know if your journal is the right place to put it, but I was doing it with the healthcare economist. But Jim, I always love to work with you. So talking about this, it is a public health issue. It's just mind-boggling. And the second mind-boggling thing, if you allow me, there is a reason I asked you to write an editorial on the systemic disease, on the systematic reviews, because one of the courses, the guy who's teaching us science-based evidence, he was a public health leader in New York City when the COVID was. And he said very clearly that governments rely on systematic reviews. And that sat in my head, because systematic reviews, as much as you try to be unbiased, you're still biased. You remember, and that's the problem. So if a government is going to take a systematic review for its whatever it is in it for granted, that's a problem. And that's why see that they're never going to see public periodontal or oral health. Let's put it oral health, dental caries or whatever as an issue, because you're never going to see it in systematic review.
And in that systematic review, you've amalgamated all these various papers, some of which have a higher degree of bias than others. And hopefully when they wrote the systematic review, they filtered out the biased papers and did not let them influence the systematic review result. But you've taken maybe one good paper, one good research, prospective, double-blinded study that was excellent, and diluted it with 5, 6, 10, 15 other papers.
Correct. And
so that one good paper, those results, which were the results we should be following, are not followed.
Yeah, that is the point. That's why I was so aggravated, and I asked you if we can write it, because it's scary. It's scary. Like in the pyramid of the ranking of the studies, they put systematic reviews above the prospective study, which is I don't know. I was really was very, so goes back to the same thing. Those discussions will never be picked up. And that's why I made it as a, I don't want to call it as a crusade that I wanted, but I wanted to have those discussions talked more and more. And I hope the younger generation will pick up on it and have more forums and talk to each other about it. And so that's the point. It's the economic impact on patient. It's huge. We are not thinking about it. But I have to prepare myself for my third bracket, right? So I'm in that limbo age. So you start thinking, it's like, okay, oh my goodness, we're going to live longer, hopefully. So and we're going to be needed to be maintained. And all the studies are there, and we have a comorbidity that we are washing it out. So it goes back to the same thing as you said, Tanvir. It is difficult to get the medical to take it very seriously, but it's not impossible. Yeah. It's difficult, but you need to keep pushing and pushing and pushing. I did a podcast with one of my referral ENT. He's a great referral to me. He is like the cleverest ENT I've ever worked with. He always said, most of the time it comes from the oral cavity. And he's right. He sends me those cases. And I take a CBCT and you see it. It's there. And they went probably to another ENT. They would have done a surgery, and the surgery never worked. And imagine the cost and the suffering, because I don't know if you had a surgery in your sinus. I had. It's not fun. Let me tell you, it's not fun at all, the recovery. And it goes without being checked, because the ENT never think about the teeth. So, but look, there is one. It doesn't mean that it does not exist. So the work is, how can we push more and more and more? Organized dentistry has not been helped. I'll be honest with you. All the academies, they've not been very helpful on that. And I'm not here to criticize anybody. I have enough on my plate. I need more enemies. But I believe that if they're doing their job the way we are discussing this, I think more people would have heard of it.
Yeah.
And,
I mean, the way you're thinking about the way later on as people are getting older and they need to be more maintained, especially with implants and procedures. The one thing I think I've noticed, and I spoke to a couple of my colleagues when they just big discussion on Facebook, is the idea among society that how on one hand, dentistry is becoming a commodity, and two, patients are expecting their dental work to last forever. If they don't last forever, they come back to your office, they refund me my money or fix it. But that same mindset is not applied with medicine. If you do a heart surgery, and a couple of years later, you need a second heart surgery, they don't tell the hospital, give me my money back. They're gladly say, okay, I need another heart surgery. I need this procedure. I need this procedure. It's okay.
It's true. It's true.
In society, I think it's the biggest problem, because one thing I've noticed when I'm talking to my patients is whenever I'm doing a procedure, I explain to them in advance, you may experience complications. You may have this in the future. You're establishing that expectation before they do a procedure.
Well, I have another. I'm going to throw you another thing. Once you're going to be in practice for long, like myself and Jim, you will see that if you put a crown on a patient, just give you an example, anterior teeth. I'm the pro of agenesis. For some reason, I've had tons of it in my life. Guess what? You put that crown in 10 years, it's going to be shorter than the teeth next to it, because we are in a constant growth. It doesn't stop the growth. So that is not made forever. So it's going to be needed to be changed and so on. You're right. They think that this is forever, but this is where we have to explain to them, when you're doing cases like this, that is nothing forever. Take one single crown on an implant, one single crown on an implant between teeth. You will see, mark my word, you will, it's written in papers, the contact will open, inevitable. And they will end up with foot impaction, peri-implant. And guess what? Because we grow, the teeth move. Implants don't move. So that's another thing that it's costly. They have to change the crown. It's going to be, yeah. And that's exactly what, you know, Jim was saying, 28,000, but a crown on one single implant, whatever, $1,500 to $3,000 or $4,000 in New York. So it varies, but nevertheless, that is another expense that somebody has not planned, budgeted for. And yeah, he or her, she or him, gonna pay for it.
So we still experience growth in the 30, 40, 50, 60. That's why we have contact opening and
it's not
I thought it stopped when you're like 20 to 30 and that growth stops now.
Keep moving because teeth will, that's why, you know, with age, you see the loss of the vertical because the teeth, they collapse and they will shrink, and that's inevitable. It's this is a fact. Actually, there is a paper in our board, periodontal board, in the renewal. They ask you that question. It is a paper. 5 years. It's a pattern that you will find it in 5 years. Same thing with peri-implantitis. You will find it within 5 years after the implant placed, if it's going to happen. Again, literature-based. That's another expense. Patients say, oh, why would I have done implant? Look, yeah, because implant is nothing forever. You know, you buy the most expensive car, you don't maintain it, or something going to happen to it, it's going to break. If you want to take it as a commodity, that's a good explanation for it. If you would take it as a health issue, it is. It's a fact of life. But the bottom line is, we have to always remember the economical impact on an aging population. That is something very important, especially when this aging population is going to become the 25% of the population, of the existing population, that is going to live on a budgeted income. And they're going to live long. And they're going to have other diseases. Periodontal disease is a comorbidity. If you can control that, you do a good service for them. That's the bottom line on this. So yeah, well, I'm glad that we're having this kind of back and forth. I enjoy it more than a lecture only. I don't know if anybody of the other participant want to ask a question. I'm more than happy. Or James, if you have something you want to swing by me and.
Yeah. And what I wanted to get your perspective on what do you think the biggest problem with academia is right now in dental school, that I feel like they're not teaching this. I didn't learn this until after I graduated. So I'm saying you have these universities, I don't understand why they can't just work together.
Can you repeat it a little bit? I'm sorry, I missed something.
I'm saying you have university. They have a let's say Harvard, for example. They have a med school. They have a dental school. They have other healthcare school. But I don't understand why don't they just work together? Because
it's a very question, and I asked that to Dean Wolf from UPenn, because UPenn and the medical is actually affecting them. They have so it's like I said, it's the problem of healthcare. Like, let me give you an example of something I lived at NYU. NYU Medical Center is an independent body inside NYU. Actually, they have their own email address, and their dean is the CEO. Actually, it's not only a dean. So it's an enterprise, the healthcare, and that's why it becomes more separate and more secluded. They have so much, they're so big that they don't have a place to think about the dental. I believe. I think it's wrong. I think that the more we can get to publish papers talking about the impact on health, on public health due to the dental, those systematic reviews will start picking up. You only can get a correlation or an impact is unfortunately, if you get more papers out there, that if somebody makes a search on the public health effect, you will pick it up. And it becomes I'm talking from an economical point of view, then it will become more relevant. And that's my message to anybody who's going to hear us, because I'm going to post that podcast on this recording on my podcast and my YouTube. Hopefully anybody will hear us and confirm and excite people. The more we write papers on the economical impact of oral health care or periodontal disease as a comorbidity for the health care, then we will have more chances that this will be picked up in a systematic review, since governments decide by systematic reviews, and then it will be more of a matter of fact to be educated in medical schools. Other than that, I don't think they are interested. They don't have the time. There is no money in it for them. So.
But even if they don't have the time and money, but we're living in a world where now we have AI. We can utilize AI to do the research,
Correct.
analyze data, and diagnose better.
Correct. But AI, you have to put AI. What it does, as a matter of fact, I had a lecture on it this weekend, past weekend. It's all about keywords. All it does artificially, it does the search for you without you doing it. So Dr. Rutkowski is the reference in this. So the papers, if you don't put the keywords proper, they will never be picked up. Even the hashtag or whatever you put on Instagram or on whatever you post on YouTube, if you don't put the right hashtags, people will not pick it up. And that's how the search work in artificial intelligence, regardless what it is. I tell you, I wrote a paper in 1998. I was the first who did a split technique on mandibular anterior. Stupid me, or I was naive, I was young. I did not know about the keywords. I did not put the right keywords. Never been picked up. Nobody heard about this paper. Compendium 1998. So if, again, what I'm trying to tell you is, it's whatever you feed the literature, that's how you can get the search engines to catch you. And that's why it is so important to publish more in that subject, and that any search will pick it up. So that's what my, again, Dr. Rutkowski is more of an expert in that field than I am. I was teaching literature, but not somebody who edit a journal. So he can tell you the importance of keywords, and that's what search happens.
I agree with you wholeheartedly on that, that when you're doing the search, the keywords and how you put everything is so important. In fact, I find myself, I am amazed how it'll be a Saturday morning, and I'll have thought of something while I was sleeping, and I get up and I run to my computer and I put in these keywords and I do this search, and I get these articles and I think, okay, this is great. This is just what I was looking for. This is a basis for it. And so I might get 30, 40, 50 papers, of which I put into my end notes, and I go back and I look at those, but then I go like, you know what? I thought I remembered something, and I'll go in and I'll just change a key word or my organization, my and or my quotations and whatnot, and bingo, I find 5 more papers. Correct. That were really important. That I had not done that, I would have missed some important things. So when, and I realize when they do systematic reviews, we always make sure we put in how we do those searches and things of that nature. But still, you've got to do it more than once, because you'll always get something different. And it's when you proofread a paper, you've heard me say it, Tanver, when I did my lecture with you folks in the statistics class there. Whenever you write something, you write it then you put it down, you walk away, you come back in 5 hours, you read it again, and you're going to edit it. It's going to be different, but you've got to do that 5 times. And the last time it has to be a minimum of 48 hours because your mind is reading it, not what's on the paper. Your mind is reading what you think is on that paper. And so this is all true with all these systematic reviews. And one note for us to be thinking about closing on here is one reason that medical schools do not necessarily incorporate dentistry into their topics as much is because on each and every topic they have, there is an information explosion because of all the literature, evidence-based literature that's out there for us now. So they think, boy, we want to talk about teeth. What are you talking about teeth? You know, I mean, those are just the guys that couldn't get into medical school. That's what dentistry is. We're over here, we're dealing with DNA and RNA and polymorphisms and disease states and cancer and all this. Who has time for this? Yet it is a very expensive proposition not to have good oral health. Period. It's
Period.
expensive.
End of the sentence. Yeah.
It's expensive.
It is expensive for a retired person, for any person, for the matter. And so yeah, there has to be a recommendation that the government has to support somehow. I don't know how, but nevertheless, it's as you said it, Jimmy. I couldn't have put it better. Period. No discussion on that. Yeah.
What if it's possible to make a proposition like that varies from state to state, where if a person goes to their physician before they get surgery or I don't know, whatever, that they have to be cleared by a dentist, you know? Like, for example, if in California, dental hygienists can open their own offices, but dental hygienists cannot do another cleaning on them in a year if they were not seen by a dentist within a year. That's an actual law. So why can't we pass that law same with the medical community?
Because you touched on something very important. We are the United States of America. United States. So every state has its own laws, and each locality in a state has a different law. It is the most convoluted system that the world has never seen. So you are talking about, but when we were in classes, and people criticize America very quickly. Calm it down. You have 360 million human beings living in 50 countries under one umbrella. That never existed in the history of the world. So this is something new as a phenomena in the world. So you can't compare United States of America to Canada, with all my respect to Canada, or to Germany, or to France, or any of these things, because they're all like a state out of this whole state. So each state has its own laws. That's one thing that I learned that was mind-boggling for me. Every state has its own laws. Not only every state, it goes down and down and down and down and down to counties and localities and municipality. And so you can't pass a law like this. It's too complicated. Like I said, the only message you have to force it is to have more proofs in the literature, more and more, until it becomes engraved in their head, because as James said it's period. There's no discussion in here. I mean, I don't know how much we're going to discuss the same damn thing. I mean, it's a comorbidity, for God's sake. Get it together, Yeah, I mean, that's what it is. It's I don't get, look, radiograph, for instance. Yeah? So you talked about the patient complaint. This is a big problem for me. Oh, I don't want to have x-rays on my mouth or radiation. Yeah. If you go to your doctor and they say, I want to do a CAT scan on you, would you say no?
No.
They will say,
okay.
CAT scan, I have no choice. Now compare the CAT scan to a PA, periapical. It's like a nuclear bomb towards a shotgun. I mean, this is... So yeah, I mean, this stupidity. How can you make a diagnosis in dentistry without an x-ray? You can't. We don't have radiographical eyes. Periodontal disease, you can't diagnose it without an X-ray. Changes around an implant cannot be done without an X-ray. Not a probe. A probe is fantasy. So what I'm trying to say is there is so much bad information giving out that supersedes the good information. And that's what Jim said, period. What we're discussing this shouldn't be a discussion anymore, but it is. It is. So so I'm glad that we're having this discussion, actually.
Yes.
So
we're going to have you back on a future one of our roundtables, Dr. Elchar. Edgar, you are a good friend. You have provided an excellent presentation. Tanver, you've contributed immensely to this presentation this evening with your comments, your questions, your thoughts, and that's why we're going to turn this over to your generation in another 15 years. I'm in the process of really turning that key now. Dr. Elchar is probably 15 or 20 years away from it. I am that baby boomer. And so we are there. And I'll say this as a baby boomer, as being a retired person, and even though I'm still very involved in doing things, it's because I want to do things. But there is a mentality that gets in your mind when you are retired, and all of a sudden you have this, oh, I know you're on a fixed income. It is. You do think about it. You think about, well, how much money am I going to? I remember I would go out to eat with my wife, and we would get a nice dinner for $50 for the two of us. And now that same meal I spend $200 on.
correct.
And at the end of the day, I go, well, how much money did I spend today? And I'm very blessed and fortunate that I've been able to accumulate money, enough money for my wife and I. But there is always in the back of your mind, well, how if that meal is $200 today, in another 10 years, is it going to be $400?
Correct.
And
on the way we're going, yes. Yeah.
Yeah.
I mean, but look at the periodontal maintenance. See, take the same thing. The periodontal maintenance. I remember when I started my private practice, it was 125. We got it at 295 now. And patients are saying, oh my God, yeah. But it cost the hygienist, the amount, the hygienist rate went up, the overhead went up, the machinery went up, everything went up. So bottom line is, how much can you contain it without going up? But this is where the patients, as Dr. Rutkowski said it, are in need for it. And that's where the problem becomes. And it is a problem. I feel for them because I don't want to raise the money on them. But again, I have to pay to survive. Right. And that's where we're becoming, periodontal maintenance is not something we make a living off of it in reality as the practitioners, but it is expensive. It's talking about a meal. Yeah. You go to any restaurant. I took my son this week and I was by myself with him. He loves steaks. Me and him on 2 steaks, we went out with almost $300, $400.
Yeah.
And I had a glass of wine. I'm just like, whoa. Yeah. But that's the reality of what we're living. But I'm still working, so I wouldn't. But if I was on a budget, it's a problem.
So this has been a great discussion. I want to thank you very much for taking the time and being with us, my dear friend, Dr. Elchar, and all the residents that are on. And I know that you'll enjoy listening to this in the tape version of it there and whatnot. Tanver, thank you for being on. Thank you for your great questions, your comments. Very much appreciated. I know this is the end of the semester, and actually that most of the professors did not have class this week, but we had class this week. So
good.
I thank you for all the hardworking people out there. I want everybody to have a happy, healthy Thanksgiving. Enjoy your families. Think about the blessings you have. We do have so many blessings. We are so fortunate. There are so many other people in this world that are suffering. that maybe they don't even have a toothbrush or a piece of floss. So if we're fortunate enough to have a piece of floss and toothbrush, we need to be sure and use it, because there are people who wish they could use that. So with that, I thank everybody, and I wish you all well, and I will see you next semester. So, and I'll see Dr. Elchar next semester as one of our professors.
Yeah.
Thank you so much.
Thank you. Have a great Thanksgiving.
You're welcome. You
Thank
too.
you.
Thank you.
Thank you,
Bye-bye.
guys.
Bye.
Bye. Oh, I'm sorry. I didn't see any other microphones. Was there anybody else who had any questions?